Welcome back, everybody, after the break. Thank you so much for coming. We've now got the JNNP lecture, and it's a real pleasure to introduce Professor Jesus Ramirez Bermudez. I actually first met Jesus about 13 years ago when I was working in Colombia, and I think we were both speaking at a psychopathology conference. It was really clear then that he had an amazing reputation in Latin America as one of the foremost thinkers in neuropsychiatry. He's currently the head of neuropsychiatry at the National Institute of Neurology and Neurosurgery in Mexico City. And he also works as a clinician and researcher there. Jesus has asked me to give a brief introduction, but I want to tell you something that you may not know, which is in Latin America, Jesus is really widely known not only as a neuropsychiatrist and a doctor, but also as a writer, and has written a number of novels. He's written a number of books, often with a neuropsychiatric flavor, and has even won fine arts prizes for his writing. If you type his name into Google and hit images, all you'll get is pictures of him with books and being interviewed and so on. It's really fascinating. So it's a real pleasure to have Jesus with us today, and I will hand over to you.
Well, thanks a lot, Vaughn, for that presentation. And dear colleagues, I'm really excited and grateful to be here. I come as a member of a team of clinical neuropsychiatrists and clinical neuroscientists and mental health professionals from my own country. And over the years, we've always looked at the British Neuropsychiatry Association as a source of inspiration and ideas. So to me, it's very significant to be here today. And I will be speaking about this topic, rethinking neuropsychiatry. And I would like to delve a little bit into the context of neuropsychiatry in the Latin American landscapes. About the landscapes, this is my own hometown. There in Mexico, in central Mexico. I will use the term the Mesoamerican landscapes because it's just the center of the country. And in this place, supposedly in the 10th century, a person was born, Seacatl Topilitzin, who became one of the most important philosophers of pre-Hispanic culture. And he was so to speak, a priest that was transforming the pre-Hispanic thought, mainly through the symbols of the god Quetzalcoatl, who was regarded as a symbol for creativity. So I hope that is also a symbol for this presentation. Now, I will try to share with you some thoughts about the practice of building neuropsychiatry theory and practice in a Latin American landscape. And then I will go into the problem of designing neuropsychiatric research in a neurological institute. I work in the National Institute of Neurology and Neurosurgery in Mexico, a large referral center. And mainly I will focus on some research on psychosis, delirium, catatonia, and autoimmune encephalitis. And finally, I would like to share some thoughts on the problem of clinical narrative as a perspective to think about neuropsychiatric cases. So in this first section, I will argue that neuropsychiatric constructs can be conceived as bridges between psychopathology and neuropathology, and as the demarcation between primary and secondary psychiatric disorders is challenging. In some cases, I will discuss the criteria used at my own institute to improve the recognition of neuropsychiatric cases. This will lead us to some conceptual debates on psychological events and its relationship to functional specialization and functional integration in brain systems. As my initial thought is that we need a functional neuroanatomy account as much as we require an integrated model of psychological activity. So if you've ever been in Mexico City, you will recognize that this is the south of the city. This is the National University. And in this area is the Institute of Neurology, very close by to other institutes of health, the cardiology, the Medical Science Institute of Health, and other psychiatric hospitals as well, like the Institute of Psychiatry. So that's why we receive so many cases that I am going to share with you today. Now, regarding the genealogy of my own school of neuropsychiatry, the neuropsychiatry school of the Institute of Neurology, it all comes down to Santiago Ramón y Cajal, the famous Spanish neuroscientist who was the teacher of Dionisio Nieto, who came to Mexico in the context of the Civil War, the Spanish Civil War, and he had been also trained in the school of Emil Kraepelin. So this man had different concerns for comparative neuroanatomy, evolutionary psychiatry, philosophy of science, but also psychiatric phenomenology and basic neuroscience as well. He was a pathologist coming from that tradition of German tradition. Now, there are many other sources of inspiration for us. You can see here some of the most important ones. Like in the case of the British tradition, I would regard as an important influence the work by Alwyn Leishman, coming through some colleagues that are around here and who we've had sometimes the pleasure to collaborate with. But also the French tradition and the German tradition. You can see some stories there that are very interesting, no? Like the case of Karl Wernicke going to Kurt Goldstein, and from there to Norman Geschwind, and from there to Antonio Damasio, Jeffrey Cummings, and Mario Mendez, but also to Marcel Mesulam, who has been one of our more important thinkers in the field of cognitive neurology and neuropsychiatry in my own institution. As well, you can see here other influences, like the German School of Neurology and Neuropsychiatry, the works by Cecile Vogt and Corbin and Brodmann, of course, but also some interesting and unexpected stories coming from Sigmund Freud to Sabine Spielrein to Vygotsky and Alexander Lurie, the Russian neuropsychologist, and all the way to Jordi Peña Casanova in Barcelona. And so we try to integrate, perhaps as many of yourselves, different influences, no? From cognitive neuropsychology, cognitive neurology as well, and neuropsychiatry. Now, I am aware that some academics regard mental disorders and neurological disorders as mutually exclusive. This is something that we see in the philosophical literature, for instance. And others think that mental disorders are always brain disorders. But I am following here the thoughts by Alwyn Leishman, who regards clinical neuropsychiatry as a field of the intersection between these two fields. And to me, it is when psychopathology meets neuropathology. I don't think that we have essential features of psychiatry or neurology, but rather I think more in a pragmatic way that what we can do is recognize psychopathological patterns and see if there is a causal relationship with neuropathological patterns. So this is the work that we try to do every day. And allow me to present one or two cases to make some general points. This is a case that we've been working recently with Dr. Max Kohlhardt from Australia. So in this case, the patient has a problem of epilepsy. She has also a left inferior quadrantanopsia. So you can see here in blue that this is the area of the visual field in which the patient cannot see. But when she suffers from seizures, from focal seizures, in that specific area of the visual field, she has the experience of visual hallucinations, which are autobiographic in nature, in its content. So we are arguing here for a two-level explanation. The patient is not psychotic. She only has this experience for about 1 or 2 minutes. But I think this can provide some general principles to understand the emergence of experiences like visual hallucinations. So we try to use here a concept coming from the School of Cognitive Neuropsychiatry, which was, I think, developed here by Dr. Anthony David and Dr. Peter Halligan, and which we think has a lot of conceptual power for us. However, we need to go into the difficult cases for that kind of relationship, because, of course, we are aware that the relationship between the topography and the psychopathology has difficult boundaries, right? So this is a case of a woman who has a psychotic syndrome. She has schizophrenia-like psychopathological pattern, and she was, unfortunately, isolated for 7 years by her mother. Perhaps her own mother had also a psychopathological pattern. We could not know because she died before we started to treat the patient. After she died, the brothers took her to the hospital, and we found that she had this brain tumors, a brain neoplasm in this, corresponding to a meningioma. And you can see that the brain lesion is affecting the dorsomedial aspect of the frontal lobe, all the way down to the corpus callosum. And at the psychopathological level, she has, as I said, a pattern of schizophrenia-like psychosis, but also a problem of catatonia. She has many difficulties in walking. She has lost the control of sphincters, urinary sphincter, and she has also many cognitive problems as well. So for us, the question is, after the surgery, will she improve completely regarding the psychopathological pattern? Because decidedly, the patient needs a surgery, but what will happen with the psychopathological pattern? So we try to make the predictions before the surgery, because surely you can agree with me that after the surgery, when everything is done and we can see the outcome, everybody says, I knew it. I knew it before the surgery. But we have to make the predictions truly before. So this is the same case 15 months later. You can see that the surgery is fairly good from an anatomical point of view. And the patient recovered completely regarding the catatonic state, also regarding the frontomedial pattern. Cognitively, she has an improvement, but she still persists with some features of psychosis. She develops a Capgras syndrome. In fact, she thinks that her relatives are imposters, and she once came to the hospital with a broken leg because she tried to escape from their relatives, so she injured herself. And she has the delusion that her mother is still alive. So that's an interesting feature, calling perhaps for an understanding from the field of, I would say, affective neuroscience, right? As it has been developed by people like Caterina Fotopoulou. So this brings us to one of the difficult problems when treating patients with psychopathological syndromes that don't align well with the classical concept of a focal neuropsychological syndrome. Myself, I think that focal neuropsychological syndromes are important keys to advance neuropsychiatry. But of course, problems like psychosis, catatonia, and others don't align well with those patterns. So I think of this coming from these concepts by Dr. Germán Berrios, who tell us in this work that different brain locations of a lesion can lead to the same symptom. But also, one location can lead to several symptoms. So, of course, we need a functional connectivity model and a structural connectivity model to account for this heterogeneity. But also we need to understand the role of configurators of the mental symptom, right? And these configurators may be biological in nature, but perhaps also cultural and psychological configurators. So, of course, we understand the role of functional and structural connectivity as a way forward in clinical neuropsychiatry. This is a work we made with late onset mania using diffusion tensor imaging to track all the functional neuroanatomy and the structural neuroanatomy related to this problem. And we need, of course, a model of brain functioning. We use the model that was published this month by Dr. Jordi Peña Casanova from Barcelona in the Cortex journal, which is a very interesting model. But I would like to stop for a minute in this slide because I think that we also need a model of psychological activity, and that seems to be even more difficult, perhaps. So we have many accounts. I think this is like a Tower of Babel, right? So we have features that use that rely on features of mental representation, of brain computation, information processing, like in the case of cognitive psychology, cognitive neuroscience, perhaps nowadays the active inference account or free energy principle account. But we also have some models coming from the fields of psychology or philosophy, like radical behaviorism, ecological psychology, radical enactivism, or even other instances like relational psychoanalysis that reject these basic features of the mind having these marks of the mental conveyed by mental representations or the metaphor of the computer. So I think we have a lot of work to do here, not only in the field of neuroanatomy, but also in trying to integrate a model of psychological activity. Now, I would like to advance to address some of the research in my hospital, having looked at these general meta-theoretical problems. This is an example of the kind of patients that we see in my own hospital. This is a sample just focusing in the problem of psychosis. These are 2,069 patients, most of them with primary psychosis, but a large proportion of them have what I would say is neurological psychosis, so to speak, no? Psychosis due to a neurological disease, mainly epilepsy, but also autoimmune disease, major neurocognitive disorders, and so on. So one of our concerns has been the recognition of this, because we have to take decisions every day in the emergency room. So we are aware of some recent works by Dr. Pollack, von Bell, and others, important researchers from this city, in which we can say, I think, that 5 or 6% of the patients with psychosis coming because of a problem of psychosis to our institutions have a clinically significant brain disease that may be seen in a magnetic resonance imaging device. But as known around the world, many psychiatric hospitals don't have brain imaging, for instance. And also we need to make some kind of decision-making to prioritize some patients. So we use this system of red flags. Some of them are not controversial at all, like seizures or an abnormal neurological examination. But others are interesting because they are part of our own psychopathological assessment, like in the case of catatonic syndrome or a severe and disproportionate cognitive disturbance. These problems, in fact, I would like to go into them through some research. So in our own institution, if we compare just, for instance, the MoCA test between patients with primary psychosis and patients with psychosis due to demonstrable neurological disease, we will see that there are significant differences in the performance in the test. Like in primary psychosis, we will have 18 points and 10 points in the patients with neurological psychosis. So to me, this is very important because in the decision-making every day, sometimes clinicians, both neurologists or psychiatrists, are very skeptical about the importance of cognitive assessment in the context of a patient with acute psychosis. Because the usual argument will be that the patient is very psychotic, so it makes no sense to make a MoCA test in that moment, or it has no meaning. But when looking at the data, we can see, to me, that it has a lot of meaning. So this can be regarded perhaps as a red flag, a psychopathological red flag. And the other one is catatonia. So in my own sample, I show you the characteristics of the sample. 3% of the patients with primary psychosis have catatonia, but 19% of the patients with a secondary psychosis have catatonia. Of course, I don't expect these numbers to be the same in other contexts, but in my own hospital, it has some value as a red flag. So allow me to show you one case that illustrates this. So years ago, we were making a survey of catatonia in our own hospital, and the main cause that we found for catatonia in our institution was encephalitis. And this is a case of a patient. She has chronic catatonia, chronic psychosis with many features of schizophrenia, like the so-called first-rank symptoms from Kurt Schneider, delusions of control, and so on. But she has an important disturbance in memory and also in visuospatial performance, constructional ability, so to speak, even with features of hemi-neglect, perhaps. She has also features of dysexecutive syndrome and visual memory disturbances. And I will show you the video. And I must clarify that the videos that I'm going to show you today, they have been always obtained through written consent to show them to you today in this academic setting. So catatonic for about 5 years, psychotic for 5 years. We used all the treatments that we could, with even ECT and, of course, pharmacotherapy without results. And after immunotherapy, we had a very good recovery. This was the first case we treated for anti-NMDA receptor encephalitis.
Aquí donde estamos. ¿Cómo te sientes?
Bien, ya me he olvidado un poquito las cosas, pero...
A ver, ¿nos puedes decir un poquito más claro?
Se me han olvidado un poquito las cosas, pero ya voy mejor.
Ya vas mejor. ¿Te dijeron de que estabas enferma?
De encefalitis por anticuerpos en mi ría.
Ok, muy bien, de eso sí te acuerdas.
Now, the patient still acknowledges some cognitive problems, and we will see that that is our main problem today. In the last years, of course, we've seen a number of pieces of research delving into the psychopathology of NMDAR antibody encephalitis. I think this piece of research was very important for us to set a context, and we studied a number of cases in a prospective study to make a clear picture of the catatonic features of the cases. And once again, I'm going to show you two cases that superficially they look alike, but you will see that there are important differences in the phenomenological aspects of the case. So this was puzzling for us. We regard this as a case of grimacing in the context of catatonia, although there were a lot of discussions with the colleagues of movement disorder in the context of neurology, but they agreed that this was mainly a case of grimacing, as opposed to this other case that superficially looks alike, but this seems to be a case of opsoclonus, for instance. No? But both are cases of anti-NMDA receptor encephalitis. And well, you can see that both are striking cases, but they had a very good recovery after immunotherapy. Now, along the years, we've made some pieces of research on the outcomes. That is one of the main problems we are trying to address today. What are the outcomes? How can we measure the response to treatment? Do we have objective forms to measure the response to treatment? These are patients with catatonia. And the next video is going to be a little disturbing for yourselves because of the sound, but well, I think it has some clinical value, so I'll let it go by. This is the same patient after the treatment.
Pues me encuentro muy recuperado, ya estoy haciendo de alguna manera mi vida normal y gracias al trabajo que han realizado, pues es que estoy aquí. Entonces, pues muchas gracias por su atención.
That was also a case of catatonia, but excited catatonia, and some of these patients can be severely agitated, and these are the usual measures that we do. We can see that after treatment, most of the patients have an improvement in overt agitation scale, also in the confusion assessment method, in the Bush and Francis, they recover almost completely. But I will show some data later on cognition, which is still one of the unmet needs. Now, this is another paper that we published recently, trying to focus a little more on different psychopathological presentations of autoimmune encephalitis. We have this group of patients that have psychotic depression with suicidal thoughts and behaviors, and also patients with delirious mania. This was one of the presentations. It was present like in one of each 4 cases in our own sample. And these patients recovered pretty well in most cases. Now, regarding the brain activity, for us, the main diagnostic system, the diagnostic tools with more value is the EEG, of course, is still the EEG, but also the molecular imaging studies, no? the FDG PET scans. This was a paper from Dr. Probasco, and then one from our own group, showing that these patients had probably important features of occipital hypometabolism. But looking at the data nowadays with a larger sample of 158 patients, we see these 5 patterns. Some patients have anterior hypermetabolism, some have posterior hypometabolism, some have an abnormal anterior-posterior gradient, and some have generalized hypometabolism. But for us, the most important marker has been the abnormal anterior-posterior gradient. This has not been published yet, but we think that it has some power as a marker for encephalitis. Well, and about the clinical picture of these patients, this is a paper we published recently. They are 100 cases of anti-NMDA receptor encephalitis, which were assessed prospectively with many psychopathological tools. And these are the features of the cases. No? You can see that there's a polymorphic picture of psychopathological picture, but perhaps the most frequent problem was psychosis. 81% of our patients had psychosis. But to discriminate between cases of anti-NMDA receptor encephalitis and patients with other forms of autoimmune encephalitis or primary psychosis or even other problems, because our sample has even some cases of multiple sclerosis or a couple of cases of Creutzfeldt-Jakob disease. But the most powerful psychopathological concept was the catatonia delirium comorbidity. And this is something that I can illustrate through this image. As you see in our sample, most of the patients come with depression or mania or psychosis, but during the evolution of the disease, they will develop at some point catatonia, most of them, and also many of them will develop delirium or at least severe and disproportionate forms of cognitive disturbance. So 8% of the patients in our sample died, and I would like to stop for a moment in this historical paper, which I found from 1965, in which these were 55 patients with states of catatonia and delirium, but they were diagnosed as having schizophrenia. And you can see that 36% of the patients from that sample died. So I don't think really they were cases of schizophrenia, right? And this is other study that we published in the last years. Here we take a different approach. We assessed 264 cases of delirium due to neurological disease. And when we found that the patient had a significant amount of catatonic signs, we, by means of a multivariate analysis, a logistic regression analysis, we found that viral encephalitis and anti-NMDA receptor encephalitis were significantly related to this. So this is about the research that I wanted to show to you today. But just to finish this presentation, I would like to stop for a few minutes into the topic of clinical narratives, because surely you agree with me that in all of our patients, the neurobiological variables are very important. Sometimes they have full causal power, but also the contextual factors can be very important. And we always need to look at the life trajectory. So the history of interactions, the history of learning, the environments of the patient are very important. So this is our model for a neuropsychiatric formulation, no? that we try to do in every case. So we need to look at the phenomenology of conscious experience. We need to look at the history of behavioral interactions, of course, the neuroanatomical picture of the patient, but also the neuropsychological processes that mediate between both dimensions. And we also need to look at the level of the organism to account for factors like allostatic overload, interoception, and so on, and to the sociocultural systems in which the patients are nested, as well as the ecological systems of relationships. To give you a couple of examples of this, I would like to stop once again into the landscapes of Latin America. This is the mountains of Oaxaca. The state of Oaxaca is a state with a lot of cultural richness. And a patient came from Oaxaca to our hospital because she had forgotten to speak Spanish. This was the presentation of the case. She would not speak Spanish anymore. Her mother tongue was another language, the Mije language from Oaxaca. And she learned Spanish as a second language. So she forgets to speak Spanish, and she develops a case of psychosis, no? with a lot of behavioral disturbances. So that was like some years ago. We did the CT scan and the lumbar puncture in the emergency room. They were normal. So the case was transferred to the neuropsychiatry unit as a case of psychosis, schizophrenia-like psychosis. That was the concept. No? A perfectly wrong concept, because later on we found in the MRI that the patient, in fact, had a case of herpetic encephalitis. No? So it became clear for us that she suffered from bilingual or polyglot aphasia due to an herpetic encephalitis. And there was a significant delay in the recognition of the problem, no? In part due to our conceptual approach, but in part also due to our lack of knowledge of her own language. Case 2 happens in a more modern city in Mexico, Monterrey. This is the case of a woman who is a highly educated woman who lived, in fact, some years here in London. She was very fluent in English, much more than me, for that matter. And she suffered from a traumatic brain injury as the result of organized crime. And as you know, we have a problem of organized crime in Mexico, which is very important. So she had a very significant brain injury due to that problem. And she survived after the brain surgery. But over the next months, she had another case of aphasia. In this case, it was a very interesting presentation because her verbal output consisted only of incomprehensible vocalizations that resembled musical sounds, devoid of verbal content. So we identified this as a case of jargon aphasia, but like some kind of hyperprosodic form of jargon aphasia. This is the MRI of the patient. You can see she has a significant lesion in the parietal and temporal lobes in the left hemisphere, as expected for a case of aphasia. But the story is interesting because she had this boyfriend who was very enthusiastic, and she was very he was very enthusiastic about her recovery. The patient was completely disabled for the moment, but he thought that he could help her. So at some point of the story, the boyfriend put some music that was her favorite music. I think it was a Canadian band, Arcade Fire. It should have been a British band, of course. No? Everybody knows that British bands are much better, but it was a Canadian band, in fact. But surprisingly, the patient started to sing perfectly in English. So she could not speak in English. She could not speak or sing in Spanish. She could only speak in English. And that was the case, no? And that led to a neurological rehabilitation program that improved her a lot. Now, the third case is more difficult in nature because it starts from one of the most marginalized areas of Mexico. This is Valle de Chalco. And in this part of the city, we have the highest degrees of poverty and violence. And the patient was a victim of violence, abuse during her childhood, but she became an independent person dedicated to working as a perfume seller. And she had an accident in a motorcycle that she used to sell her perfumes. And after the accident, she had this terrible brain lesion affecting mostly the left hemisphere, the temporal lobes. And she also had a case of jargon aphasia. But what was interesting in this case was that she was able to make calculations. So she had a completely preserved numerical cognition, even when she had the most severe case of aphasia that I've seen. But she could make calculations. So as she was a seller before, we made this kind of situational therapy program in which she would sell popsicles in the street. So you know, in Mexico, the cars stop for 74 seconds, no, in the streets, and a lot of people come selling different kind of stuff. So the patient would even compete with other people selling stuff in the street in those 74 seconds. And she became very successful selling these popsicles, no? And she would do it without words, no? Because she didn't have any, but she would sell the popsicles, and she became so successful that she was even stolen by her relatives. They even stole her income once. But she never took the attitude of a victim of misfortune. She had a bewildering enthusiasm. So when I see cases like that, of course, I ran out of words. No, in fact, right now I don't have anything else to say. This is the end of the presentations. This book was entitled A Dictionary Without Words, because the patients didn't have any longer, at least for some moments. So if you allow me to do it, I will leave the final words to the Argentinian poet, Jorge Luis Borges, who reminds us that we are already the forgetting that will be. I am not the fool who clings to the magical sound of his name. I think hopefully of that man who will not know that I was on earth. Under the indifferent blue of the sky, this meditation is a consolation. Thank you very much.